All right. Good morning, everyone. Welcome. We're just going to let everyone just gather in, and we'll just get started here in just a minute. Okay, well, let's go ahead and get started. Good morning, everyone. My name is Darshan Mehta. I'm the Education Director for the Osher Center for Integrative Medicine at Brigham Women's Hospital, and I'm also the Medical Director for the Benson Henry Institute for Mind-Body Medicine at Mass General. It's really an honor to be with my colleagues and with Jim this morning. We will, I'll just introduce Dr. Loewenthal in just a moment. But just wanted to welcome everyone to our Integrative Medicine Grand Rounds series. So as some of you know, we alternate between a research Grand Rounds presentation and a clinically focused Grand Rounds presentation over the course of the year. And this will happen on the first Tuesday of every month from 8 to 9. For those of you who are requesting CME credit, you'll see the information placed in the chat on how to get your CME credit for these Grand Rounds. Our next Grand Rounds presentation, just to give a preview, will be on Tuesday, March 2nd, and that'll be a research-focused Grand Rounds by Dr. Rebecca Wells, who is joining us from Wake Forest, and we'll be talking about, does mindfulness help migraines? What does the evidence show? One researcher's journey to understanding this question, and her work is will be based on a recent seminal paper in JAMA that was published on this topic. So without further ado, let me introduce, it's really an honor to introduce my colleague, Dr. Julia Loewenthal. She received her degree from University of Virginia and then completed her medicine residency at Brigham and Women's Hospital in the primary care track, and then completed a fellowship in geriatric medicine in Beth Israel Deaconess. She's board certified in internal medicine and geriatric medicine. And what is also what many of you may not know about her is that in addition to her clinical experience in medicine, she's also a yoga practitioner and teacher, and has really developed a strong interest in stress and aging, as well as healthcare provider well-being. And I've had the privilege of working with her over the past now 5 years, hard to believe, and really learned quite a bit from her as she is delving into thinking about medically complex older patients. She's also the course director for the Harvard Medical School Healthy Aging course. And so I will turn it over to Dr. Loewenthal, who will obviously introduce our amazing panel here as well. So, Julia.
Thank you. Let me just set my screen up here. All right, so thanks again for the honor of presenting Grand Rounds today. And I'm joined by a wonderful collection of speakers who are all centered around our patient, Mr. Jim Kelly. So we have Dr. Amy Peters, who is a neuropsychologist at Massachusetts General Hospital, and Dr. Zeina Chemali, who works as a neurologist and a psychiatrist at Mass General Hospital. And finally, Mr. Kelly's primary care physician, Dr. Stephen Atlas, will be joining us as well, also from MGH. And so as our presentation unfolds, we'll get a chance to hear from each of our speakers. And at the end, we'll have a panel discussion for questions where we will all be present to help answer any questions that come up. So again, thank you for the honor of presenting today. I have no disclosures to report. And I want to just start with this picture. This is yoga teacher Tal Porchon Lynch. and she held the Guinness World Record for the oldest yoga teacher. She actually just died this past year at age 101 and was still actively teaching and holding retreats at Kripalu, which is a center for yoga in the Berkshires. So I actually got interested in aging from the perspective of mind-body medicine and especially yoga practice. We see examples of yogis and other practitioners of mind-body medicine who age very well into their late 90s and early 100s even. And I think, this could be maybe that people who age well are just naturally more interested in mind-body medicine and these methods. But I also think there's something going on here. And when we use these methods clinically, we really see improvements in both the mind and the body across the aging developmental span. And so when we talk about aging in geriatrics, we think a lot about health span, which is not just how long you live, but how healthy you are throughout your entire lifespan. And so this is kind of the perspective in which I found geriatrics in my medical training. And I want to also start changing the conversation a little bit to talking about healthy aging. So this is a campaign from the city of Boston called Age Strong. And this campaign was launched to help dispel negative stereotypes about aging. So this, you may have seen these ads at bus stops or around the city in the past couple years, but they often take a word like cranky and they try to give something that would spin that and put it on its head a little bit. So, I mean, this campaign is really amazing, but it really features people who look like they're functioning well. They do not have disability, and they seem to be really engaged in life. And so when we think about the practice of clinical geriatrics, we also think about this patient. So this patient is somebody who has disability, they have functional impairment, and yet they're still out in the world and engaged in the community. So how do we really define what is healthy aging? Is this person not healthily aging just because they're using a device? And so as a geriatrician, when we think about our approach to patients, we like to try to incorporate flexible definitions of healthy aging and try to be very inclusive in these definitions. And so that brings us to the definition of healthy aging. There really isn't a single definition. One of the most popular definitions is from Rowe and Kahn, and this is the idea of successful aging. So successful aging in this framework is considered to be made up of three components. So that would be avoiding disease, maintaining high cognitive and physical function, and engaging in life. Now, as we get older, especially into our 80s and 90s and 100s, very few people meet all three of these criteria throughout their entire aging trajectory. And this model has also been criticized for placing an overemphasis on individual control and not accounting for some of the social and cultural determinants of health. So when we look at healthy aging, I actually quite like the WHO model from the International Classification of Functioning, Disability, and Health. And this model really emphasizes the importance of some sort of meaningful activity, and it incorporates functional status, people's ability to participate, health conditions, in addition to larger contextual factors like the environment and social and cultural determinants of health. This model is not restrictive. Anybody can really be in the center here, regardless of disability, cognitive or functional. And you'll notice this model is actually not age specific. So you could think about this as being suitable for a younger adult or a middle-aged adult as well. In the practice of geriatrics, we've traditionally focused on the most frail of the oldest old. That paradigm is starting to shift a little bit. So some groups, like our group in the American Geriatric Society, the Healthy Aging Special Interest Group, have been advocating for a shift to focus on healthy aging across the lifespan. And this is a framework we actually recently published about healthy aging during the COVID-19 pandemic. And again, we're just highlighting here that it's not just your mental, physical, and cognitive health, it's also social engagement and managing health conditions. So in the clinical practice of geriatrics, we really lean on the comprehensive geriatric assessment in order to approach healthy aging from a clinical perspective. So that we assess all of these different domains to identify people's strengths and also their vulnerabilities, and then to try to form an individualized plan for the patient. The concept of frailty is something I just want to touch on here. And so when we think about the differences between these two women here, we think about this concept of frailty, which is also a concept that's familiar to the field of integrative medicine as stress reserve. So frailty is really the decreased physiologic reserve resulting in a decreased ability to tolerate stressors. And we can conceptualize frailty with this graphic from this Clegg Lancet article, seminal article in 2013. And I think if you look at this from the perspective of a mind-body practitioner or from the perspective of a geriatrics practitioner, it really rings true in both fields. So we know that people who have higher resiliency are more able to tolerate minor illness or stressors. And then people who are frail or who have a lower physiologic reserve are really taking a larger setback with each stressor, and then they take a long time to recover and then may never return to their prior baseline. So when we approach a patient clinically in the field of geriatrics, we try to map vulnerabilities by domain. So this is a frailty index calculator that was developed at Beth Israel by Dr. Day Kim in geriatrics. And I love the way that this is displayed. And so the frailty is displayed along these different domains in a network display. And we have areas of vulnerability graphed out here in blue. And so we can see, for example, this patient had higher levels of vulnerability in their medical domains, but had more strengths in mobility, muscle strength, and functional status. So this is just to give you some insight into what happens during a clinical evaluation of an older patient. And this is just another display of how we might use information from all these domains. So the purpose of a comprehensive geriatric assessment traditionally has been to prevent and manage geriatric syndromes, like things like delirium and falls, cognitive impairment, etc. But we can also start shifting to thinking about how do we positively promote healthy aging from an assessment of all of these domains. And again, approaches from integrative medicine are well suited to help address the promotion of healthy aging here. So integrative medicine offers many multimodal therapies that address body, mind, spirit, and also community factors. You can think of some multi-component approaches from yoga and also Tai Chi that incorporate physical activity, breathing practices, meditative components. And so I think we're seeing a lot of potential applicability from the field of integrative medicine into the promotion of healthy aging. And some of the, again, examples, I've touched on things like yoga and Tai Chi, but at the Osher Center, we pull from all of these different methods when we approach our patients and evaluate them clinically. So I want to move quickly actually into our clinical case, because I think this is really why we're all here today. And so I want to just present Mr. Jim Kelly's history, and then I'll also give him a chance to flesh out some of this with us in a few minutes. So Mr. Kelly presented as a 69-year-old male to his primary care physician with forgetfulness. He has a past medical history of major depressive disorder, concussion, alcohol use disorder in remission, moderate hearing loss, tinnitus, hypertension and hyperlipidemia, prostate cancer status post-prostatectomy, and non-melanoma skin cancer. His medications include bupropion and escitalopram for depression, hydrochlorothiazide for hypertension, and then a vitamin D supplement. In terms of his social history, he reported a normal developmental history. He has a high level of educational attainment to the master's degree level, served in his career as a hospital executive, and then when he retired, he worked as an elected official. He's married and has 2 children, and reported no other substance use. And in his family history, he reported no history of neurologic disease. So Mr. Kelly initially met with his primary care physician, Dr. Atlas, who we'll also hear from in just a few minutes. He was also seeing an ear, nose, and throat or an otolaryngologist, and this was an evaluation for dizziness. He was referred to Dr. Chemali at the MGH McCann Center for Brain Health, and then for neuropsychological testing with Dr. Peters. He was also referred to the Benson Henry Institute, and then found his way into a SMART program with me through the Osher Center. So we'll touch again on this timeline as we go, but I want to just shift now into asking Mr. Kelly to just fill us in a little bit more on some of the symptoms that initially brought him in for evaluation.
Good morning. So really from about 2 years, or beginning about 2 years ago in earnest, I had some memory loss. Examples of that are losing my keys, forgetting the location of my parked car, failing to remember at the end of a conversation all the things we were talking about. I've noticed that my processing speeds were slowing, especially when in meetings with several participants. I began, for hearing, asking for people to repeat what they were saying, especially in crowded places. I felt a real increase in anxiety as a result of this, feeling I was getting old, feeling a little powerless over it. In my career, I maybe took a perverse pleasure in doing many things at once. I liken it to the example of the person who puts plates on sticks and gets them spinning and keeps them spinning and rushes around. And I had to go from topic to topic and group to group for a number of things, operational and strategic. And I found in my personal life that those plates are starting to fall off. I wasn't able to concentrate in the ways that I had been before. I also found that and this is possibly related to COVID, but I certainly was in a less socialized situation in my work life, and in my volunteer life, I encountered many, many people in a day. And lately, in the last year or so, I've been sedentary with my wife at work. So in July of last year, I reported to Dr. Atlas that I had increasing falls, the tinnitus was worsening, dizziness, memory, easily forgetting things. And then I had the referrals that Dr. Loewenthal just alluded to. So that's really what brought me in.
And Jim, could you comment a little bit on some of the changes you experienced with retirement? Because that seemed to be important.
So certainly the world continued around me, and I wasn't, this sounds egotistical, but I wasn't, at the center of activity anymore, which I particularly enjoyed. It was easy for me to sit back. I wasn't prodded to do things. I wasn't required to do things. I wasn't expected to do things. And so I had, a requirement for really, more self initiation, which sometimes I didn't do. And the world started to slow down. And that's really kind of what I've.
And then you were working as an elected official, I think right until COVID happened. Is that correct?
So, yeah, I was the chairman of the town's finance committee, where I lived part-time for 7 years, and then I was an elected official with the governing body of that town, and that ended in April of 2019, and then subsequently COVID. So they were not quite aligned, but close to it.
And did you notice that your symptoms increased at any particular point in the last 2 years or so?
It's hard to say whether, they increased or my awareness of them increased. I noticed when I was more active, I didn't really have the time to think about this, or if something happened, I dismissed it because I was busy quickly doing something else. But certainly, I noticed really although they were mild symptoms, but in the summer of 2019, 2020, was when they seemed to be exacerbated. I began to really, forget kind of where I'd been or what I'd been doing, or people reminded me, no, you didn't do this with me, you did it with somebody else. And those were pretty scary things. All the other symptoms I had was I began to fall. I actually fell upstairs. And that was also a big concern. So I had a consultation with physical therapy and had some improvement there.
Great, thank you. I want to move a little bit and give Drs. Atlas and Chemali a chance to jump in here with any comments.
Sure. Hi, I'm Steve Atlas. I'm a general internist at MGH. As a general internist, we take care of a wide range of different, both physical and mental health issues. And Mr. Kelly, had a number of these things. When he mentioned, actually, it was a virtual visit over the summer. It wasn't an in-person one, which always makes evaluations more difficult. He mentioned sort of the memory, the dizziness, the falls, all the things he described. From a clinical perspective, I often think about, okay, is this a neurologic condition? Is this, is this normal brain aging for memory, or is it abnormal brain aging? And as a clinician, we can do more medically about vascular issues. So hypertension, lipid, sugar, things like that. If it's more of a primary neurologic process, we know that there's limited treatment options. We don't have good ones for that. So I often focus on what things we can do. So he mentioned balanced hearing. So I often think about sort of the senses and what things can we fix in that end. And to that led to sort of interest in having him work with physical therapy around balance, having a hearing evaluation, sort of more practical things from a medical perspective that may help. There's also, as Jim mentioned, sort of stressors, anxiety, depression, sort of change in life events, and those obviously can play into it as well. Just from my talking with him, it did not appear that he had sort of a primary serious neurologic condition, and that also, and that was sort of a gestalt, obviously, over telemedicine, but that also led me to pursue sort of the potentially remedial sensory issues that we started with. Thanks.
Thank you.
And I'll just wait till the end as a panelist, so to give you time, but happy to take any questions later.
Thank you. Great. And then Dr. Atlas, one more question for you. With some of your older patients during the COVID pandemic, are there any other changes you've noticed as a primary care physician just caring for older patients?
I think Mr. Kelly highlighted several of those that we see. One is more sedentary, and two, just the stress of 2020 was not a year that we're going to remember fondly for at many levels, not just around COVID, but just our whole social discourse. And I think stress, anxiety, being cooped up, were things that were widely, are sort of a dime a dozen now for a general internist.
Yeah. Great, thank you. All right, so I'm going to transition into introducing Dr. Amy Peters, who's a neuropsychologist and who is the one who performed Mr. Kelly's evaluation. So I'll turn it over to you, Dr. Peters.
Great, thank you. So, as the neuropsychologist on Mr. Kelly's treatment team, our focus is really on the clinical evaluation of these brain behavior relationships. And the emphasis really involves understanding what are the cognitive symptoms or potentially other behaviors of concern. So what does this look like in daily life? How is that affecting the patient's day-to-day functioning? And then we take a very systematic look through the administration of behavioral tests to get a quantitative index of the patient's current level of functioning. You can do 2 slides forward. And so for those who may not be especially familiar with our service, this allows us to contribute, I think, several different types of potentially useful information to the patient and the broader treatment team. So firstly, our cognitive testing can help establish a diagnosis, which may be a cognitive diagnosis based on the extent, pattern, and course of observed cognitive difficulties. Or the results of testing may help inform or distinguish, as Dr. Atlas was mentioning, in kind of core neurological dysfunction from primary psychiatric diagnoses, such as depression. Secondly, we can inform cognitive status. So what I mean by that is that when a diagnosis is already known, such as traumatic brain injury or stroke, but it's nonetheless helpful to understand what is the range or severity of the deficits that are present. And then thirdly, we think really carefully about how the evaluation can inform other aspects of patient care and address what are the implications of any deficits that are seen, and also how do areas of relative preservation, how can those be used to promote recovery of function. We try to help other providers think about whether the patient can return to work, drive, live independently, if they would benefit from different types of particular therapies that they're not already receiving. And then also, how can we use those areas of strength to compensate for weaknesses via different types of cognitive strategies. And then lastly, where necessary, the neuropsychological evaluation can be a tool for monitoring cognitive course and future functioning. So once someone's had an evaluation, we can do an apples to apples comparison of test performances over time to establish whether there's progression of disease or improvement, having a response to a particular treatment from a cognitive perspective. Next slide. So a few of these themes I think were already starting to come up a little bit from the other speakers, but a really common question, and I think a few of the things that Mr. Kelly and team were hoping to try to piece apart when there are initial memory or other cognitive concerns as during the kind of aging period. And a question that can often promote a lot of anxiety is this dementia? Or perhaps are the cognitive concerns manifestations of depression, of anxiety, or caused by other stressors? Or is this just normal aging? So that even if there are mild changes that are present, do those changes sort of fall within what we would expect for age? Next slide. So then taking a bit of a look under the hood as to how we actually accomplish this. The first step of our evaluation is to use what we know about the patient's educational and occupational history, as well as select assessments that we administer of reading and vocabulary, since those are domains that we know are very insensitive to decline in things like primary Alzheimer's disease or other dementias. And we use that to estimate the patient's pre-morbid level of cognitive functioning, so sort of the optimal baseline that we expect them to perform across domains. Then we take, of course, a detailed patient history and do a record review with particular attention to the aspects of course, symptoms, and functioning that may inform a cognitive diagnosis. And then we also, pay close attention qualitatively. So we yield objective test scores from our evaluation, but equally sometimes how a patient approaches a test, as well as just how they present to the exam in terms of their speech, motor function, mood, social comportment, engagement with the overall process can be equally important. And then we do administer an extensive battery of standardized tests that ultimately generate norm reference standard scores, which allow us not only to look at the individual who are evaluating their profile of individual relative strengths and weaknesses, but also assess to what degree those scores are normal or within a normal range for their age or educational background. And we do this across the full spectrum of cognitive domains, from sort of basic orientation and arousal to intelligence, their attention, their executive functioning, and where relevant, we'll assess things like language, spatial perception, certainly learning and memory, as well as emotional and psychiatric functioning. Next slide. So to this end, this is a summary slide of Mr. Kelly's cognitive testing scores, which individually are labeled across the x-axis here. And on the y-axis, we have age-corrected z-scores with a mean of 0, such that a score of 0 or greater reflects average or above average performances. And if you could advance, yep. So what I want to draw your attention to first and foremost here is that Mr. Kelly's profile does not have any scores falling 2 or more standard deviations below the mean. So this is essentially the range that reflects a low or very low score at the tail end of a normal distribution. And so when we see scores in this area consistently within 1 or more cognitive domains that are perceived to represent a change from the estimated cognitive baseline, and that can't be sort of accounted for by other aspects of the patient's history, is when we would start to consider making a diagnosis of a mild or a major neurocognitive disorder. And if you could advance one more. And in fact, quite the opposite for Mr. Kelly is that the vast majority of his scores fell within this range, reflecting generally average to high average scores, which on the whole were pretty consistent with his estimated baseline. If you could advance once more. However, the one thing I will point out is that there were a couple of, and this is where a lot of our discussion and sort of follow-up focused on, is that there were a few scores falling approximately 1/2 to 1 standard deviation below the mean. Now, it's important to appreciate that these scores are still within what's considered normal limits, but they're at the lower end of the average range. And so these are skills that reflect areas of what we would say are relative weaknesses, especially when we are considering that Mr. Kelly's sort of estimated level of functioning overall likely falls in the high average range. And these couple of skills that were on the lower end here really hung together in the sense that they reflected difficulties with developing an approach to a complex or very unstructured task, to using and applying organizational strategies when learning new information, or being able to take a relatively simple skill but having to apply that under time demands or time pressure and really rely on fluency. Next slide. And so, these performances and his history led to our impression that, his cognitive abilities on the whole, so even taking into consideration those relative weaknesses, were fully within normal limits. And so for that reason, at this point, his profile didn't rise to the level of a cognitive, even a mild cognitive disorder. Next slide. But notwithstanding, I think the evaluation was still really helpful for elucidating these areas of relative cognitive weakness, especially in light of the concerns that Mr. Kelly came in expressing and how they were impacting him in daily life. And so every single person has individual strengths and weaknesses. And so, the things that were really identified here as more challenging were these more strategic or organizational components of how to learn and remember information, as well as some other aspects of attention and executive functions. Next slide. And so then drawing on his history and our conversations to try to think about, well, why might this be the case? I think first and foremost, Mr. Kelly did share sort of after the fact that to some degree, these difficulties may reflect a kind of long-standing pattern of individual strengths and weaknesses that he had observed to some degree in other settings at other points in his life, but that were particularly pronounced within his current or more recent social environment. And to that end, it seems that there's some situational exacerbation that's secondary to some of these ongoing personal stressors, to some fluctuations in mood and energy, or to periods of anxiety that can make it more challenging to apply these cognitive skills successfully in his daily environment. And as he mentioned at the beginning about his presenting concerns and being worried about the nature of these symptoms, especially when there's ongoing stress or anxiety, that can also engender this heightened sensitivity to both the actual difficulties that are being experienced in daily life and also perceived cognitive errors. So in other words, sort of worry or anxiety about those cognitive symptoms. Next slide. And you can sort of advance through these as I go through. So given this context, one of our primary recommendations was to continue developing stress reduction strategies and skills for management of mood fluctuations and anxiety that, in turn, we hope will continue to result in being able to think more clearly and have greater capacity for attention, to reduce worry and concern about cognitive symptoms. I know Dr. Loewenthal and Mr. Kelly will talk more about the SMART program later, but one observation that he had by the time of the feedback session was that he felt his cognition was already really improving over the course of a group mindfulness-based intervention. But we also talked about some compensatory cognitive strategies, which for the sake of time, I won't go into great detail about now, but in essence are really focused on imparting external structures in one's daily environment to reduce the burden or demands of one's own executive functioning cognitive resources. And we provided resources that both of these types of interventions could be completed in individual or group settings. And then additionally, given some of the kind of ongoing fluctuations in mood and energy and motivation that were expressed, we thought that a medication consult would be helpful for optimizing antidepressant treatment. And that along with general healthy lifestyle habits like regular exercise and healthy eating, that these recommendations together would hopefully put Mr. Kelly in a good place to develop skills to address and compensate for his current relative weaknesses, but also just really promote sort of optimal and healthy brain aging moving forward. And so to our view, a reevaluation, we're certainly here to reconsult in the future, but would really only be necessary if Mr. Kelly continues to experience persistent or worsening cognitive concerns. So lastly, next slide. I thought I'd just touch briefly, if those are curious about sort of the evidence base for using stress reduction as a means to improve cognition, that I talk about this one particular paper. Admittedly, there is quite a broad literature on mindfulness-based stress reduction and cognition that is a bit mixed, but partly because it spans a really wide variety of different types of patient populations. And this paper in particular is the only study that has evaluated mindfulness specifically for older adults who have some initial subjective cognitive concerns and who are also experiencing depression and anxiety symptoms. And it's also one of the few papers that's done an actual randomized controlled trial with a health education control condition that's really matched for the intensity of the mindfulness-based intervention. So basically, this study assessed memory, attention, and executive functioning, as well as psychological functioning before and after treatment with either mindfulness or this health education control. And basically what they found is that while both conditions experienced some improvement in memory at retest, which is expected because of the practice effects that we tend to see on our tests over time, but that patients in the mindfulness condition showed a greater improvement in their memory scores. Interestingly, they also demonstrated improvements in their depression, their worry, and anxiety over the course of treatment. And so although this wasn't a direct test of mediation or a mechanistic type study, it does sort of start to lend credence to this notion and our clinical experience as providers that stress reduction techniques that we know improve anxiety and depression can also in turn yield some concurrent improvements in cognitive symptoms. So with that, I think I will turn it back to Dr. Loewenthal.
Great, thank you. So I'm going to go do a brief overview of what the SMART program is. I know a lot of people in the audience might be familiar with the SMART program, but for those who aren't, I just want to do an overview. So this is the stress management and resiliency training program offered and developed at the MGH Benton Henry Institute for Mind-Body Medicine. And in the SMART program, participants work in 3 different main areas. So the first is building skill in eliciting the relaxation response, which helps counter the stress response. The second is decreasing stress reactivity by increasing awareness of their stress response. So how does it feel when I'm in a stress state? What are my physical symptoms? How do I behave? What kind of automatic thoughts come up? And then the third is starting to practice adaptive strategies. So things like healthy lifestyle behaviors, working on social connection, working on some cognitive strategies like reappraisal and coping. And so all of these go in to ideally enhancing somebody's resiliency and reducing their vulnerability to stress. And the program is offered in an 8-week format. It meets currently virtually, but in the past in person for 2 hours a week. So that's just a little bit about the kind of the structure of the program. And I want to highlight just a little bit of the science about cognition and stress, just because it's relevant to our discussion today. So stress affects cognition and thinking in multiple ways. We've already covered a lot of this with Dr. Peters' content so far. But I want to highlight the role of the prefrontal cortex, which is highlighted here in purple. So this is the area of the brain that's responsible for a lot of higher cognition and also organizing goal-directed behavior. It connects to higher levels of the cortex to regulate other thoughts and actions. And it also projects down into the limbic system where the emotion center, amygdala, and other structures sit. So when we're in an alert, non-stress state, the prefrontal cortex regulates these areas of the brain in a top-down manner. So it's really in control and kind of telling these other parts of the cortex and also in the limbic system what to do and not to do. However, when we're exposed to stress, multiple factors, including circulating levels of catecholamines like norepinephrine and epinephrine, can take the prefrontal cortex kind of offline. So that's when a lot of our conditioned emotional responses come out, and a lot of our sort of habitual responses come out. And this, the limbic system here then activates the stress response system, thereby increasing stress physiology in the rest of the body as well. So some of the skills that are learned in the SMART program include things like meditation. There are lots of other skills like yoga practice and other things that are touched on in the SMART program. These are two studies. I probably will skip over these just given our time here, but two studies just looking at meditation and brain structure. This first one looked at long-term meditators versus naive meditators, and it appeared that long-term meditators had thicker areas of the brain, including the prefrontal cortex. And then this study here looked at meditation practice and specifically the hippocampus, which is the region of the brain responsible for memory storage. And it looked like meditators had thicker gray matter in the hippocampus, among other regions. So these studies are limited. They're cross-sectional typically. This one's cross-sectional in nature. But I just want to highlight that there are potentially some correlates to mind-body practices and people's brain structure in addition to function. So I want to actually give Jim the floor again to talk about his experience in the SMART program and some of the skills that he learned and practices.
I guess I'll first start talking about, I guess in general, I was unconvinced that I was under stress. I had no reason to be stressed along the lines I always considered: financial instability, medical issues. I had a loving family, so it quickly became evident that I was under stress. Very simple tests like, do you hold your breath when you're in a stressful situation? Yes. So that awareness really led as an impetus to be very open to the suggestions and training we did. I'll talk about mindfulness in the beginning. I can't overestimate the impact that mindfulness had on my, situation. I mentioned falls before. Well, I was, live on the third floor of a building and walking up the steps, and I would actually fall forward. And that totally went away when I began learning or having more skills related to mindfulness, because before I was running up the steps and thinking about what I was going to do when I got inside, and I wasn't mindful about the world around me. Mindfulness helped my breathing techniques, and just so it was very impactful. Meditation also was very impactful. Let me just give you a quick example. So many of these things are now incorporated in my daily life. It's hard to parse out which had what improvement, but certainly meditation. These practice notes that we do are very impactful, and I've kept some of them. And let me just read. The first 2 days I started with meditation. The first day, my comments were: started in bed, then on the floor with pillows under knees, became very dizzy, head spinning, had to stop. That was my first experience with meditation. The second day, I was sitting. I was able to focus better, and I was able to do it for 7 minutes. When I looked at these the other day, I was really shocked, because now, daily meditation is just part of my daily life. I can go for as long as I want. Sometimes it's a couple minutes, sometimes it's 20, sometimes it's 30 minutes. In the beginning, it was all guided meditation. Now I'm very comfortable doing it on my own. And I'm able to get it in a good place pretty quickly. So that's been very helpful. I guess, let's see. Certainly, the other kind of reflection I had is this is training. This is something that it's a process. Like you take medications and you feel better. You don't really have to do a lot on your own. This is something that takes action and investment in time and energy. It's really helped me also understand. It's really given me an interest in brain health, which I've enjoyed reading about. But I always thought about retirement as a time to look back and, my accomplishments and, where did I get in the world and what could I have done better? And this SMART program has really given me a perspective that, I have a whole new opportunity for development. In terms of my future, I'm very positive about it. I, want to become more engaged. I'm not going to go on, but those were just in general, some quick thoughts. Thank you.
And Jim, let me ask you one more question. So you had also noticed some changes in your relationships and communication style. Can you just reflect a little on some of the things you noticed?
That's a nice way of saying my family has said, Dad, you seem so much calmer. You're nicer. You're not as cranky as you used to be. When you talk to us, your questions about more about my life and not necessarily just yours. So those are some. And my daughter over the holidays said, "Whatever you're doing, keep doing it." So had that impact.
Great, thank you. Well, I think so. It's I think what we'll do is transition into panel for any questions from the audience or other comments that our panelists want to make.
So let me, I just wanted to first of all, thank everyone for what a stimulating discussion thus far. And I thought one question I would ask, sort of as the moderator's prerogative, is really to understand, and maybe Zeina, I'll start with you since you're the medical director of the McCann Center for Brain Health. How do we go about, this is a comprehensive 360 approach, and you obviously run a clinic, an operation that focuses on a comprehensive 360 approach. How does the average patient seek consults and care? And I thought maybe this might be a question for all of the discussants here, that to coordinate all these different dimensions that have been talked about.
Thank you for the question. I also want to say that I answered one of the questions in the chat about a certain neurosteroid, but how people come to our clinic, actually, it's a very open clinic. Anybody can refer to us. We have a very strong relationship with primary care as well, both at MGH and the community. And it is for any brain health issues, for people that are absolutely without any symptoms, or for people that are worried because they have a family history of something going on, neurodegenerative in their family, or if they have any kind of, okay, there is nothing going on, but what can I do to boost really my brain function? And so we take a very holistic approach as well. And I think that Mr. Kelly can also attend to that, is as the brain doing everything from motion, from emotion to cognition to social interaction. We're heavily based also on techniques and actually referrals to meditation, meaningfulness in life, assessing stress, and seeing. Unfortunately, this is what happens in that clinic, is how much early onset of adverse events actually can track for people really when they are aging. I mean, that is amazing. So please visit us. You can get to the McCann Center. And we have also developed what we call an ideal brain care score. And patients, actually, we do ask them that. And at the end of the visit, they will have an ideal brain care score towards which they actually work through the recommendation to better it. Once also we meet with them again and again. So don't be shy, just come on over and hopefully we'll be able to address all of those issues together.
Mr. Kelly, I'm just curious from your perspective, when you see all of your providers, you have your primary care provider here, you have a neurologist, a psychologist, a geriatric specialist, a neuropsychologist. How do you feel, you know, as a patient, seeing sort of this sort of multidimensional care as it relates to healthy aging?
Well, it's a real privilege to be a patient. As my first response, the ability to have access to this, world-class care is phenomenal. I found that it wasn't hard to sort through and kind of find resources, especially with Dr. Atlas's help. My observation was that you were all very good at kind of circling back to primary care, supporting primary care. And I felt as a result that it was very kind of, I guess, virtually integrated. So those were a couple comments.
Dr. Atlas, I'll sort of now sort of punt it to you in terms of as a primary care provider and having to coordinate all of, what is it like, and especially when we think about healthy aging and in this sort of patient population.
Yeah, as a generalist, Dr. Chemali has to be careful what she asks for. The reality is that I could send half of my patients to her. As being an older physician, I have an older patient population, memory issues, anxiety issues, many of the things that we've talked about are very common. And I think one of the challenges I face and most generalists face is who do we refer to? Who do we send people on to? In Mr. Kelly's case, a lot of it was his own self-motivation to wanting to be open to explore these things. Some patients aren't aware of it. Some patients aren't willing to think about it. They're looking for a diagnosis of something, Alzheimer's or whatever. And so it's much harder. So my challenge to the specialist is, how do we help me and my patients sort of figure out who will benefit from your services, so that we don't overrun you all. That's sort of my fear. Be careful what you ask for.
Well, so I'll turn it over to our last, first to Dr. Peters, just as a neuropsychologist and doing these very comprehensive neuropsychology. What do you look for as, how useful is sort of having repeated evaluations once things are established at the outset?
I think it certainly depends on a lot of factors, but I would say the sort of stage of cognitive course is really important, right? So I think a lot of times the reevaluation tends to be probably most frequent among a group of patients falling into that sort of mild cognitive impairment category when we do render that diagnosis, to see, to be able to monitor progression and sort of need for services over time, or when it's a condition where there is a clear plan for kind of medication intervention or perhaps neurosurgical intervention where we're going to monitor response to treatment. When behavioral strategies are put in place and there's not necessarily a formal cognitive diagnosis that's rendered, that's a place where, and this is something Mr. Kelly and I discussed, that it's more up to sort of the patient and how they're feeling about where they're at in consultation with their other providers. Because certainly, the neuropsychological evaluation is intensive, so we don't want them to have to sort of redo all the formal testing if things are going well. But by the same token, if it is helpful to get an index of that and sort of confirm that, we're also happy to do so in a targeted way. So.
And Julia, you get the final word. As you do an integrative geriatrics consultation, what are the things that you think about as a part of sort of a consultant role, and especially in an integrative geriatrics clinic as you do it at the Osher Clinical Center?
Yeah, so I sympathize with Dr. Atlas. I spend most of my time working in the primary care setting. doing geriatric co-management. So I do appreciate the sort of volume and need of the patient population in the primary care setting. So I try to bring that balance into my evaluations at the Osher Center, which is more of a specialty practice. So in an evaluation, I would do a comprehensive geriatric assessment, usually over 1 to 2 visits, where I would look at all those different domains that we covered early on in the presentation. For people who have cognitive or mood concerns, which is more of what Mr. Kelly had, although he did have some difficulty with his mobility, and also he had sensory impairment with his hearing loss. But for people who have more cognitive or mood concerns, we can definitely pursue referrals like this if they're interested and motivated. If there's a little bit less interest in having further clinical evaluations, I try to work with them on tools and resources they could use on an individual level, or refer them to group programs. So I might refer them to a psychotherapist. I might give them some meditation practice in the office that they could then take home. So it kind of depends on the needs of the patient. And I think regardless of what level of cognitive impairment a patient is at, except for moderately severe dementia and beyond, I think patients can usually benefit a lot from social connectedness, lifestyle behaviors, stress management, treatment of clinical mood concerns, and that can help all along the cognitive course. So that's just a little bit of some of the approach we have. And I'll just flash to kind of this is our division of aging here at the Brigham and some of our sites that we practice at, and then highlighting the Osher Center, and then also putting a plug in for My Healthy Brain, which we've heard from earlier this year during the series. Right. So some of the resources we use.
Well, this, as you can tell, this is a discussion that obviously needs a round 2. And really thank you. First of all, thank you, Julia, for spearheading this multidisciplinary panel. And thank you to all these distinguished colleagues for their expertise. And obviously, most importantly, thank you, Mr. Kelly, for sharing your story with all of us. This is really a treat. Very rare occurrences where we get to see such a broad, diverse, multidisciplinary panel along with our patient present their experience and perspective. So thank you to all of you for being here. This has really been an amazing Grand Rounds. Just as a quick reminder from the beginning, our next Grand Rounds will be on Tuesday, March 2nd from 8 to 9 by Dr. Rebecca Wells of Wake Forest. And she's going to talk about her work, Does Mindfulness Help Migraines? What does the evidence show? One researcher's journey to understanding this question. Again, please connect with us at the Osher Center website, www.oshercenter.org. And these Grand Rounds will be uploaded, the recording, onto the website for review afterwards. So thank you, everyone, again, for a stimulating discussion. And we look forward to seeing you next month.
Thank you. Thank you all.
Thank you, especially to Jim. Thank you.